It is wonderful to see you all here today. Thank you so much for joining us all on this session about Health Data Research UK and why public, patient and practitioner involvement engagement is just so important and fundamental to everything we do at HDR UK. So I thought I'd just start off by just reflecting on our mission, which is to unite the UK's health and care data to enable discoveries that improve people's lives. And we've seen through all of COVID that actually data underpinning discoveries around who a disease is affecting, how it's transmitting, what treatments or vaccinations are working, what adverse events are kind of associated with them, which ones don't work is also equally important. And this work is, and that's been very important through COVID, but I think the point I want to make is it's also true for dementia, for mental health, for cardiovascular disease, for cancer, for rare diseases. It really is true that data does save lives. And so I just want to kind of touch on a couple of aspects then. So what does this mean about public and patient involvement, why that's so important? Because I think there's key aspects in our mission statement. So we're using data that's about all of us, and we're wanting to use it to improve all of our lives. So to improve my life, your life, anyone else's lives, we, the patients, the public and practitioners have to be involved. This is an absolutely crucial part of just good design and development and activities in there. But it's particularly important with data research, where we are just more abstracted from the individual by the nature of looking at large numbers of people. And I think it's important to think through what doesn't happen if you don't involve people, public, patients, practitioners in the research. You end up, first of all, with two things. One, and I'm sure many others, but two that just I wanted to touch on today. The first one is you end up with mistrust in how data is being used and by whom. So Honora O'Neill, a public philosopher, puts it very nicely. And a quote from her is that we need to think much less about trust and much more about being trustworthy, and how you give people adequate, useful and simple evidence that you are trustworthy. And I'd suggest that for data use, this means involving patients, public practitioners in decisions around how data is used, particularly around data access decisions around who is using data and for what purposes. So the first one is that, so my first point then is effectively, if you don't get people involved, you're getting mistrust in how data is being used. The second one, equally important, is that you get less good research happening and more limited discoveries from the data. So for example, you need to be involving people to be able to understand the condition, how they're experiencing it, what data you would even want to capture about it, to understand how they're experiencing the symptoms in there, but also to understand whether you've actually got the groups of people who are experiencing symptoms represented within the data. So a number of aspects in terms of real tangible involvement of public, patients and practitioners is absolutely crucial and essential to health data research if we want to get discoveries from using data that really does actually improve all of our lives. So I couldn't emphasize more strongly how important this is and how exciting it is to be having these conversations with you. So I shall hand back to Ben at this point.
Thanks so much, Caroline. And I very much agree with a lot of what you said. So I've been asked to give a kind of brief introduction to myself and my involvement, but I also want to talk about the three Ps that you mentioned in your PPP. IE. So I'm a lay member on the Science and Infrastructure Committee and was a founder member of HDRUK's Public Advisory Board, and really I got involved through my work on engagement, engaging communities. So I've been active as a local community campaigner where I live in South London for a number of years on things nothing to do with science, things like planning and parks and green spaces, and ended up getting accidentally elected as a local councillor at one point, but also involved in science, particularly online engagement and how to engage people in understanding science. And my day job is at Nature Medicine, a scientific journal. And one of the things that I'm very passionate about is patient and public involvement and engagement. But I think it can be a very unhelpful acronym. I think a lot of acronyms become very unhelpful because it then becomes very easy to tick a box and saying, well, we're doing PPIE, but you may be doing one P or another. You may be doing the I or the E, and they're not all the same. And of course, Caroline's mentioned the practitioners as well, a third P, which again is very distinctive. For me, if we separate those, the two Ps, involving patients for me is just non-negotiable. If you are using patient data, you need to be involving patients in the research, because they know what improvements will have the greatest impact on them. And as Caroline says, it will also improve research. I think the role of the public is quite distinct, but is becoming increasingly important, particularly in this kind of age of biology that we're living through, where advances in the biological sciences will be changing our everyday lives, just as advances in physics changed technology in the early 20th century. And, we've heard the announcement that every baby is going to have their genome sequenced potentially in the UK, and that requires a public discussion. It requires trust to be built, requires public acceptance, questions around privacy, commercial access are really important. And of course, a member of the public who doesn't have a genetic condition or who is currently healthy may have a different view on that to somebody who more clearly sees the benefits of something like sequencing their genomes. So I think those are both important, but for different reasons. I think also involvement versus engagement is always a hot topic in these kind of discussions. Really, with patients, it should be involvement. It should be co-production. And one of the things that I think all of us involved in HDR UK are pushing for is more involvement of patients, real genuine involvement of the public. And one of the things that I always think is, touching on your point around, Caroline, that you need to show you are trustworthy. I think it's not our job to persuade the public that data sharing is a good thing. You need to show what you're doing. You need to involve the public and patients in that discussions, and then they will decide whether they think every aspect of that is worthwhile or not. And if members of the public decide they don't want their data shared, or they don't want it accessed by commercial companies, then you need to work out why that is, and you need to have a willingness to change your mind. Researchers, need to have a willingness to change their mind, delay research, modify research, alter the way that they're framing questions. And I think that to end on a positive, I think HDR UK has really been exemplary, particularly during the pandemic, in continuing to push for patient involvement, whilst frankly a lot of people have dropped it. And I think that's something that I've found very worrying during COVID, is the number of people who've dropped PPIE. And some of the best research has included patient involvement, and that's why that research is world leading, a lot of which has come from the UK. So that's my my thoughts. Hopefully some food for thought for everyone. I now want to introduce Ben Gordon, another Ben, who's Executive Director for the Health Data Research Hubs and Data Improvement.
Hi everyone, I'm Ben Gordon. I am, as Ben Johnson's just said, I'm an Executive Director at HDR UK, and my role is overseeing our strategy area for improving the data. So essentially making the data more that researchers use more useful and impactful for research. And you'll see in this diagram here that improving data is one of our three strategy areas, alongside uniting data, so bringing that together, and then using it for research and innovation. And you'll hear more about uniting and using from my colleagues David and Melissa shortly. So what does improving the data mean? Well, in some ways, this is potentially the hardest area to kind of communicate and convey, because there's a lot of behind the scenes work that goes on in making data more useful for researchers. And a large part of that takes place through the work of our health data research hubs. So on the slide here, I've just given a list of different things we use to in the area of improving data, but a big part of it takes place through the 9 health data research hubs that we now have across HDR UK. So this is a program that was initially funded through the government's life sciences strategy, and each of our hubs has a specific area of focus. So they may range from inflammatory bowel disease, cancer, eye health and ophthalmology, or one that was particularly important over the past 18 months, Breathe, the hub for respiratory health. So each of these hubs is a collaborative partnership of organisations across the public sector, including NHS organisations, as well as charitable bodies, other research organisations like universities, and some commercial and life sciences companies. And each of the hubs works together to support researchers in understanding the data that they're using and the subject matter area, and undertaking research to deal with the specific conditions or areas of focus of the hub. We've recently just announced 2 new hubs that are joining the network. So that's Alleviate, which is funded by the Medical Research Council, and Versus Arthritis. I'll be looking at the subject of chronic pain and arthritis, and DataMind, the hub for mental health. So each of these hubs, as well as actually supporting research into their particular area of focus, also works to make data more useful and help researchers to understand it. And I'll give you one of the examples of the types of challenges we face in this area. So across the NHS, there's a huge amount of data that is available for research and can support understanding in more detail about the types of conditions and treatments that people suffer from and can be supported by. But in many cases, the data is collected in very different ways across different organisations. So, for example, a researcher trying to look at the impact of a specific treatment on and how that varies across different demographics will encounter sort of data being collected in very different ways. So you can see here just a piece of analysis we've done looking at different ways that organisations in undertaking kind of COVID data collection have recorded traits such as ethnicity. And so with very different ways of collecting and capturing data, work needs to be done at the kind of national level to bring some consistency and support researchers in being able to undertake this really impactful research at scale. So across the improving area, there's a number of aspects of patient, practitioner, and public involvement that have taken place already. And much of it is expanded in much greater detail in our recent Improving UK Health Data report, which shows the impacts from the first 18 months of the original 7 health data research hubs. And there are some fantastic case studies in that. And so each of the hubs has a very kind of rich and innovative approach to involving patients in the public. And that's something that each of them have really kind of worked with their local communities, particularly those kind of relating to specific hospitals or the charities that are involved in the hub. So for example, the Gut Reaction, the hub for inflammatory bowel disease, has very strong links with Crohn's and Colitis UK, and so has a very active involvement in the decision-making process in the hub, as well as the kind of dissemination and wider communication of the work of the hub through those charity links. And so many of the hubs have really sort of moved the needle on kind of best practice in PPPIE through the past 18 months. That includes things like setting up data trust boards to support the decision-making process on and give people kind of greater say in how data is used for research. And there's great examples of that in Birmingham with Insight, the hub for eye health, for example. There's also a fantastic example of engagement through the Citizen Summit that took place in London, bringing together kind of 100 sort of representative Londoners to talk through some of the big challenges and big questions on use of data, and that took place basically just before lockdown came in I think late January last year. And so some of the things that have come out of that, I've given an example there of a sort of data set infographic that came out of Pioneer, the Hub for Acute Care, showing in as clear a way as possible the types of data that the Hub provides and undertakes research on, so that it's clear how this data is being used and how it could support improving outcomes. And I think one last point I'll make on the on improving the data is, because a lot of our work takes place in a sort of very technical space of developing data standards and quite kind of complex frameworks. A number of times the feedback we've been given is that it's not very interesting. So we've had we've recently developed a framework for understanding the usefulness of a data set for research, as a way of kind of capturing some of the technical and qualitative details about a data set. We undertook a number of public-facing workshops on that, and I think a challenge we continue to work through is communicating some of what we think is important and impactful work in a way that is kind of easy to understand. Because when we took the time to articulate what was happening and give a clear message, we had very strong support from our public workshop attendees. But just noticing that in dealing with some of these technical issues, it does take a number of kind of stages or goes to get the point across. So continuing to work with patients and the public on how to communicate those messages clearly and succinctly, I think is an area we'll continue to work on. So I'm very happy to take questions at the end, but I think now I am passing back to Ben.
Thanks. Yeah, well, please keep there's a few questions already. Thanks, Ben, for that. A few questions already in the chat. If you keep those coming, we will take all of those at the end. So I now will hand over to David Seymour, who's the Alliance Executive Director. David.
Thank you very much indeed to the Bens for that. So yes, David Seymour, I'm Alliance Executive Director at obviously HDR UK. And I'm going to talk to you about the Uniting the Data stream of work. I wrote on this earning the trust of patients and the public, but from the earlier comments, perhaps I should have wrote demonstrating trustworthiness to patients and the public. Just a quick bit of context. When we talk about uniting the data, we're not talking about bringing this all together in a sort of a single big store of data or a sort of data lake type thing. We're talking about the potential to bring together the data, to unite the data, to get greater scale, whether that's greater sort of population coverage, whether that's greater sort of time horizon coverage around individuals, or whether that's around different sort of modes of data, if you like. So how can we perhaps bring imaging data alongside genomic data, routine care data, etc. So that's the sort of the context for the uniting the data piece. And really just in terms of where we then sort of fit into the HDR UK strategic plan, you'll see here we've got sort of four sort of really sort of areas where we've got sort of goals set. One is around the gateway, which I'll touch on briefly. One's around the alliance, then around standards and around training for the infrastructure. And I think that sort of capability building is a really important part of what we need to do across the piece. You see our two goals are very much focused on, as Caroline was mentioning earlier, about how do we make sure there's efficient and safe access to that large scale data, but in a safe and trustworthy way. And also then how do we, as a component of that, how do we make sure there's transparency of that use of health data to patients and the public. So first of all, I'm aware there are some familiar faces on the call, but many I think will probably be quite new to this. So I just wanted to give a quick outline as to what is the UK Health Data Research Alliance. Well, as it says on the webpage, we're an alliance of leading health and care research organisations that are united to establish those best practice principles and standards around the ethical use of UK health data for research and innovation at scale. So it really is very much about trying to bring together what we term data custodians. So these are people who are looking after these various different types of data on behalf of the data subjects and making that data accessible and available for others for those trustworthy users. It was established in February 2019 as part of a thing called the Digital Innovation Hub programme, which again, Ben touched on the hub side of that. It's really bringing together the hubs, the alliance, and then the gateway. The data custodians that we talk about are organisations like NHS Digital from an England perspective in terms of a national body. Also then NHS trusts, particularly it tends to be the larger sort of teaching hospital trusts. So that might be University College London hospitals or University Hospitals Birmingham, for example. We've then got research cohorts. So these will typically be sort of developed out of academic institutions, but also some of the more the larger cohorts around the Genomics England and UK Biobank. We've also then got the health data research hubs and the medical research charities. And they're all guided by principles of participation, letter of intent, of which our first principle is about demonstrating active and ongoing engagement with patients and public. The Gateway then is a portal or a platform that enables access to health and data for tools for research. It doesn't hold the data itself, it holds the data about the data. This thing called metadata and the descriptive information. And that really is trying to bring together and provide greater discovery and accessibility of these different data sets, but also to use it as a platform for really sort of driving through on changes of behaviour. And that's just one of the things I wanted to briefly touch on, that really, I guess, what we're trying to do within uniting the data within HDR UK is really about influence and change behaviour. You see on the slide here a model for this, which is drawn from work from McKinsey and Company have done on sort of adult learning principles, and really understand what it takes to make people do things in a different way and understand why they're doing it in a different way. And we're trying to cover off all of those things because as HDR UK, we don't actually own or control any of this data. It's very much about working through others, influencing others, whether that's through the Gateway as a system, whether that's through standards to establish the best practices, whether that's about through our community work, having early adopters, or whether that's about training and sharing best practice. And in terms of how we then involve the public and patients, well, I thought it was helpful to say there's probably three different ways in which we do this. Firstly, we do get that direct input, which is absolutely essential. And we've had some superb input from obviously the Public Advisory Board, but the wider groups in terms of HDR UK voices and lay representation in workshops, input and commenting on documents, providing ideas. We're then also really fortunate we've got a wider network of this sort of community of PPIE sort of people that are involved in this through our hubs, but through other alliance members. And then I think it's also really important that we're drawing in outputs from sort of national sort of consultations, national dialogues. So, I mean, Ben mentioned a sort of regional one in terms of the One London one, but then there's obviously been the recent work from the National Data Guardian and understanding patient data. And so how can we take that input and use that to help us develop our approaches going forward? So it's not just about getting those key individuals, it's about trying to bring all the pieces together. So just to provide you with sort of three examples of that, I wanted to touch on data use registers, data access management, and the Gateway redesign. So in terms of data use registers, so these are basically also termed sort of list of approved studies or list of approved projects, data release sort of registers, and it tells the public, tells everybody, it's an open record of what data is being used, for what purposes, by whom, and for how long. And what we were trying to do is to say, well, actually, how do we bring that together in a more coherent and consistent way and make sure that these are available for everybody? And we started that work through with getting that public and patient involvement to say, well, actually, what are the requirements for public accountability and transparency? And you can see on the last list of the left-hand side of this slide what that list is. So what do people really want to be able to see and get from these data use registers? And we've used those inputs whether that's around sort of format, around the sort of trustworthiness of the information itself, how easy to find it is and navigate, to really sort of guide the work in this field. And we're sort of over the next day or two, we'll be publishing a green paper on this, which will aim to set out how we see others adopting this going forward. And again, that's all been driven off and initiated really from the public and patient input. Similarly with influencing data access governance. So this is a paper that we're going to our Alliance board next week, and it's been written by our public advisory board, who've shown great leadership on this, taken a survey of what's happening currently across the piece, and now given some really tangible and practical recommendations for Alliance members to adopt. And so we're hoping the Alliance members will be supportive of these. We've already had support from the National Data Guardian around these, and that this will give us, again, a great sort of way forward for Alliance members to really demonstrate how patient and public are involved in that crucial bit of decision making around data access. And finally, in terms of that sort of transparency piece, it's very much about the Gateway is one of the vehicles in which we can do that. And we're sort of grateful to all the members who have helped on these sort of information and brainstorming workshops to really help us develop the Gateway to make sure that the way it communicates is effective for both the research community, for innovators, but also for patient and the public who come to that website and understand and realise what's going on. So there's now a specific page, there's instructional videos, there's glossary of terms and frequently asked questions that have all been co-developed, tested, and retested with an engaged sort of public and patient panel. So I'm going to stop sharing there and pass back to Ben, I think.
Thanks very much for that, David. We'll now move smoothly on to Melissa Lewis-Brown, who's the Chief Science Strategy Officer at HDR UK. Melissa.
Yeah, okay, so hi, and my name is Melissa Lewis-Brown. I'm the Chief Science Strategy Officer at HDR UK. And thank you for the opportunity to come and speak to you today about how HDR UK members use health data to make discoveries that benefit patients and through good patient and public involvement and engagement. So you've already heard from David about uniting health data, you've heard from Ben about improving health data, and now I'm going to talk to you a little bit about using health data. So there are kind of two aspects to using health data that I'll speak to you about this afternoon. So one is making research discoveries through science, through data science, and the other is about upskilling the community to be able to use health data. So I'll start off by just speaking a little about the ways in which we embed public and patient involvement and engagement through the process of making research discoveries that improve people's lives. So we have a raft of projects going on across our sites, across the 4 nations, around these 4 broad research priority areas. So using data-enabled approaches to understand the causes of disease, for better clinical trials, to improve public health, and for better care across the NHS. So we have a portfolio of projects under each of these headings. And I'm going to speak to you about a couple of examples of PPIE under a couple of these. Each of these areas has an oversight board, and I just wanted to pick out Better Care in particular, that now has public and patient representatives on their oversight board. So they're involved in all aspects of Better Care national priority. And work that they've done recently includes planning for our second quinquennium. So we're in the process of thinking about what HDR UK will be doing in our next 5 years, once our first 5 years comes to an end. So the patient and public representatives on that oversight board have been intimately involved in that planning. So that's one mechanism by which we work public and patient engagement and involvement throughout our in that national priority in particular. So just to speak to you about a couple of specific project-based examples of public and patient engagement. So one of our national priorities is improving public health. And this takes a data-enabled approach to making observations from which insights can be gleaned for patient benefit, but moving from observation through to intervention and implementation as well, with a focus on reducing socioeconomic inequalities in health in particular. So one project that I wanted to speak to you about in terms of the PPIE approach is a project that looks at improving the lives of people living with multiple long-term conditions, often called multimorbidity. So this project aims to understand better which diseases and conditions are found together in people, how they develop as people age, and also critically which cause the most problems for individuals and the health service more broadly. So this project is bringing together data from 6 different geographical regions across the 4 nations, and we'll be using data that's representative of around 10 million people across the UK. And it has a strong PPIE stream to it. So it has a 12-member PPIE co-production panel, and 2 public members sit on their scientific steering group. Those lay members are linked with various patient groups across a range of conditions, because of course, multiple long-term conditions can vary from neurological disease to heart disease, and pretty much everything in between. And I think one of the areas in which our public and patient members have been particularly helpful and kind of drawn in for this reason is to understand which combination of diseases cause the most problems for patients, because this is a very broad area. If we're not careful, we'll end up sort of trying to boil the ocean here, because there are so many different combinations of illnesses that can occur in people. So they've been very helpful in helping us, helping this project to understand which combinations of diseases to focus on. And ultimately, the aim of this work is to allow researchers and healthcare workers to better plan how to deliver care to people with various clusters of disease. So a second example that I'll give in terms of project-based PPIE is in our Better Care national priority. So this priority aims to embed data-led insights into clinical decision-making. And one example that I'll give is the RADAR project. So this project uses artificial intelligence, machine learning, and so on to help clinicians and patients understand which factors contribute to complications of diabetes. So there are various complications relating to diabetes, including cardiovascular disease, eye damage, foot damage, and so on. And there are various factors that contribute to those complications relating to diet, physical exercise, and environmental factors and things like that as well. So there is a PPIE panel involved in this project in particular, who have really helped to shape the project as it's progressed. So there have been a series of online workshops with the project team and patients to really help patients understand the benefits of the form of artificial intelligence that's being used in that app, and what the benefits are for people living with diabetes. That patient panel have also tested the tool. They've suggested ways in which to make it more applicable to them, more user-friendly, and also critically to kind of give feedback on how informative it's been to empower them to make decisions for improved health in terms of managing their diabetes. And similar workshops have been held with clinicians to find out how effective the tool is in their clinical decision-making for patients. And there's a quote there from one of the PPIE members who's been involved in that. So they've made direct contributions to the design of that app so that it's most impactful for patients and for clinicians. So those are a couple of examples of project-based sort of PPIE interventions. And I just wanted to talk about kind of a pre-project mechanism of embedding PPIE as well. So as I mentioned, we've got a range of projects going on across each of those national priorities and across our geographical sites. And we have these 5 kind of flagship national projects underway, which started about a year and a half or so ago. So I've already mentioned the National Multimorbidity Project just now. We also have a project that looks at different molecules in blood samples to see how they can be used to predict disease. Also another project around understanding how data from wearables like Fitbits and so on can be reliably used to predict disease. And and so so we put a funding call out to our community for them to send in proposals for these national implementation projects about a couple of years ago or so. And when these projects came through, some of them had exemplary PPIE strands to them, really well developed, and some excellent people leading the PPIE elements work packages of the work. Other proposals weren't quite so strong in that area. And actually, Ben Johnson, our chair this afternoon, sat on the funding panel for this scheme and was very helpful in identifying those projects that needed a bit of help to strengthen their PPIE elements. And so for those projects in particular, we actually sent the proposals back to the researchers and asked them to resubmit a proposal once they'd had a chance to strengthen the PPIE elements of their work. And again, Ben was really helpful in supporting them in doing that in that time. And then they sent their proposals back in, and as a result had a much stronger PPIE element to their work, which has stood them in good stead now in terms of improved science. So just to finish, just a couple of notes on the other side of the using health data portfolio. So around training, so upskilling the current and next generation of health data scientists to be able to do good, meaningful PPIE in their research. So our training portfolio aims to attract diverse people to work with health data, upskill them to safely use health data, and then enable them to apply those skills across a vibrant landscape in terms of the health data research landscape. So we have all sorts of training formats that we offer, so internships, MSc courses, summer courses, a whole raft of ways in which we upskill people. And our overall aim is to train 10,000 people over the first 5 years of HDR UK's existence. But we don't just want to upskill those people in kind of hard technical skills in terms of, how to do machine learning and so on. We also want those researchers to know how to engage and involve public and patients and practitioners in the research that they do. So PPIE training is embedded across these different ways in which we provide training. And I just wanted to call out this middle one in particular. So we have a new virtual learning environment upon which we have a whole raft of bite-sized video modules, which train people up in various different skills that relate to health data research, including a public and patient involvement and engagement module. And other modules are in development. In fact, there will soon be one from our very own Sindhuja Manohar. So look out for that in the next few weeks. So that's a whistle-stop tour of a few of the different ways in which we try to embed PPIE in the using health data portfolio. As others to take questions later.
Thanks so much, Melissa, and thanks to everybody who has already commented in the chat. Please do keep your questions coming in. I'm making notes, and some people are asking similar questions that I'm going to group together. So there's a great discussion if you want to see the chat. But on to Lara Edwards, our final speaker for today, who's Senior Programme Manager for the Data and Connectivity National Course Study. Lara.
Many thanks, Ben, and thanks for inviting me to talk today. So first of all, I'll just give a really quick introduction to what the National Core Studies are and how that fits with the Data and Connectivity National Core Study that we're leading at HDR UK. So the National Core Studies are a small number of key studies and research infrastructure programmes which were set up quite early on in the pandemic by Patrick Vallance and the Government Office for Science. And they were really set up to ensure that the research was in place and the infrastructure was in place to allow those kind of essential and outstanding COVID-19 operational questions to help inform the COVID-19 response. So each of those has a different lead, and these national core studies you can see along here in blue are really the research-focused studies that are conducting various research studies across the 4 nations. And across the bottom in orange, cross-secting all of those national core studies is something called the Data and Connectivity National Core Study. And that's led by Andrew Morris here at HDR UK, and we lead that in partnership with the Office of National Statistics. And our role really is to enable the data infrastructure to be available for those key research questions to be answered within the national core studies. We work with various delivery partners to do this across the 4 nations, so NHS Digital in England, Save in Wales, and Northern Ireland Health and Social Care, Scotland, Office for National Statistics, and Open Safely in Oxford. And really, the main study aims are first to ensure that we are mapping those really priority health and admin data sets that are required by the national core studies. Enabling the development of the data infrastructure, so ensuring that those data assets are onboarded to secure trusted research environments across the 4 nations that allow secure access for approved researchers only. And then go back to the gateway that David highlighted earlier, we ensure that all of those data sets are findable and accessible via Health Innovation Gateway. And all of the current national core study data sets are on the Gateway, along with the various collections that we've set up across each of the national core studies that contain things like data sets, projects, and outputs and tools from each of those projects. Currently, there are around 88 data sets for those national core studies that have been onboarded to those secure environments across the 4 nations, and have been used now for research. And today is about patients in the public. So I really just want to highlight how we've involved the public so far. We really obviously want to ensure that working with patients in the public is shaping the work that we do and prioritising the work that we do through data and connectivity. And we do this in various ways. We have a public advisory board, which is 4 members on it. We work with really closely, and they really help us to ensure that we are planning and measuring PPIE properly. They help us to write content and ensure that any outputs we add to our website or reports are laid and engaging, accessible, and meet the needs of the public. They ensure that all of the work that we do throughout the study, through study setup, so prioritising data assets, how we communicate that to the public, through to the research outputs that researchers are producing are transparent. And we do that in various ways. We produce monthly reports onto our website, and we've got a public-facing website as well where we update all of those reports also. And they really work with us also on those kind of challenging and complex issues that may affect public trust. And I'll run through a couple of those examples today. But in data and connectivity, we're working with data access, and we're enabling new linkages with data sets. We've done a lot of work around vaccine safety. So we've involved the public and patients at every step in those projects. So this is just a quick example I wanted to run through that we were involved in with data and connectivity and AstraZeneca. So AstraZeneca were evaluating how an investigational drug for a trial could treat patients who had mild to moderate COVID-19 symptoms to help prevent them then developing further severe COVID-19 symptoms. And they came to us to really ask for some help around recruitment because they were having difficulties in recruiting in the community. Oh, apologies. There you go. So the PPIE activity really focused on supporting AstraZeneca as they looked at ways to kind of improve and speed up the recruitment of people into clinical trials with the community. And our PPIE activity really focused on how acceptable the public viewed that and how they felt about being contacted by researchers to take part in a trial after they've received a positive COVID-19 test result. So you can see on the left side, there was a quite high acceptability. Over 80% of people said that they found it would be acceptable for researchers at Oxford University to contact us. And similarly with Test and Trace, we worked with the Test and Trace team and Oxford University, who were the lead study site for the trial. So there was slightly less acceptability for Test and Trace to contact the public, but only slightly so. And then the next question we asked them is really how soon after receiving a COVID-19 positive test should they be contacted, and when would people feel comfortable about receiving an invite? So by far, most people indicated that they would prefer to be contacted by email, and that was really just to ensure that they had time to digest the information, that they were sure that the information wasn't coming through a scam route, that it was coming through a kind of official Test and Trace or Oxford University route. And we also asked them when would it be acceptable to be invited to a clinical trial. And again, most people thought actually it would be as soon as they were given a positive test or very soon afterwards. So just to kind of highlight the additional information that the public wanted to know in this public scoping exercise, there was three key areas really. So information about how the data was being kept and how it was being kept secure, who was accessing the data, how it was being passed on, reassurance that it was only being used for non-COVID related research and other uses. And obviously, kind of key to this was the role of AstraZeneca as a commercial organisation. So what did it mean for AstraZeneca to be the sponsor of a study? How would they have access to the test results? And then transparency, obviously, on how the data would be used and how AstraZeneca would profit. And also the study itself, of course, you know, it was obviously key at the kind of that early information point when people were contacted just after the test result to ensure that they had really clear information about the study, the safety, the protocol, the risks and benefits of taking part. And I think the key thing that I want to get across today from this was really how did this impact and how did this change practice? Well, the consultation led to some real changes in the approach. For example, the script the test and trace team used firstly asked how people were feeling, just to ensure that they are that they're up to, they feel well and they feel okay and they're happy to be talked to and find out about the trial that day. And it was also really key that they identified themselves very early on as from the kind of official test and trace team to ensure that people weren't worried about spam calls, etc. And the second key example that I wanted to pull out from data and connectivity is how we're involving the public in our funded research. So in December, we launched a funding call across the UK for researchers to apply to use and enrich those data and connectivity national core study assets that are now available for secure approved researchers access. We eventually funded 12 projects. And we involved a public advisory group from the very beginning in this process. So our public contributors advocated for PPIE to be a really strong funding criteria. They reviewed each of the initial PPIE plans that were submitted by all of the projects. And all throughout, our advisory group have been involved in monitoring the PPIE activity at specific milestones. But we've had really helpful feedback again from public contributors on what worked and what didn't. And those learnings have resulted in the co-development of best practice guidelines for research funding calls that we will now implement for future funding calls for HDR UK, but that we've also disseminated across all of the other national core studies to ensure that they're implementing best practice guidelines. And one of the key things that came out from that, that exercise was that you know, it's really important for researchers to include really good, clear English summaries for all of their research applications. They needed to be really clear as to when they would involve the public at different stages of the project, because that wasn't often clear. And then we've also produced kind of really clear guidelines on how we review and score funding applications effectively to ensure that we can be really sure that their PPIE will be robust. And then finally, just again, guidance and monitoring and ongoing evaluation of PPIE plans, because that was really important for all of these projects, to check in at specific milestones to ensure that the PPIE plans that they developed were actually happening and identifying where they might need support. We're just about to launch another research funding call for data and connectivity, in which these best practice guidelines will be implemented. So I'll stop there and just highlight that on the HDR UK website, we've got public-facing information for the public on all of our progress and impact and all of the work that we do.
Thanks, Lara. A really great selection of talks there. We've had a really good discussion already in the chat, and I'm going to start pulling out some of those questions, because there's been some similar topics that have been raised. And if you would like to ask a question, either put it in the chat or raise your hand. So in some cases I'm gonna merge questions together that are on similar topics. So forgive me if I kind of edit your question, but we've had a great question from Marion, which led to some discussion in the chat on when shared decisions are made, the patients and public on whatever committee are often in the minority, and sometimes it feels like something of a token gesture. So how can we make sure that patients and public representatives are listened to or empowered. And I think I'd like to start with Ben on this. Maybe David has a view on this as well.
Thanks, Ben. And yes, it's a really good question and a really important topic, because I think, as I can see from the chat, a number of people have a range of positive and negative experiences on that. So I think there is definitely more work to do. The thing I would point to as an example of good practice is data trust boards. So Insight, the hub based in Birmingham, focused on eye health, has developed a specific board to review research requests that come in, and the makeup of that board is quite sort of well balanced in terms of the proportion of patient and public and practitioner representatives working alongside members of the hub. So that's certainly something we'd advocate for more organisations taking up.
Anyone else got a quick thought on that? I'm going to try and get through about 4 questions in 5 minutes, so short answers, please.
Just a suggestion. Oh, sorry, David, you were going to go.
No, go on, Melissa. It's fine. I'll say it.
Thanks. I was just going to say that I think again, kind of going back to best practice, I think it's a good idea, and it's often the case that there's a requirement to sort of report back to lay members of the board in those circumstances, to let them know how their views have been taken forward. So I think that kind of, and someone raised that in the chat, I think as well, that I think is a really important part of meaningful PPIE to have really strong communication and make sure that those boards do report back to share what impact the public and patient members have had. And I think that's a good way to make sure that patient and public feedback is, there's some accountability there, particularly as, often I agree, lay members are normally in the minority. So to kind of take, a stronger accountability strand is important there, and might help to amplify those voices.
That's great. Thanks, Melissa. And then there was, again, a couple of people were asking this. Francesco and Shukrat both asked about access to data. We've talked a lot about access to data. Does this include patient access? So are patients able to access their own health data as well as researchers? And if not, what are the barriers there? I think I'm interested, David, if your thoughts on that.
Yeah, I mean, I do quick one. I mean, I guess the main thing is, given that it for individual access, I mean, that's clearly, if you want an issue for the NHS. I know that I've certainly personally got access to my primary care record via the NHS app. And that does allow you some access to some of the secondary care information, if that's obviously then included within things like discharge summaries. So if people haven't already got access to the NHS app and their clinical record and they want to, then I'd certainly recommend that. As I say, it doesn't really, from a research point of view, given we're sort of dealing with de-identified data, it's not really an area for us to sort of influence.
Okay, and then a question from several people we're discussing, Hilary, Diana, Rebecca. Has patient and public involvement improved because of remote working? Because it may allow people who have accessibility issues to be more involved remotely. But I suppose the flip side of that, raised by somebody in the chat, is, do you miss some people who are digitally excluded, perhaps people from low income backgrounds? So how do you think that will carry on after the pandemic in terms of face-to-face versus virtual involvement? Melissa, would you like to take that one?
Yeah, I mean, from my perspective, I think that kind of moving online in the last 18 months has hugely increased the number, the kind of the volume of public and patient involvement engagement. I'm sure Sindhuja could speak to our new HDR UK Voices network, which has expanded, exponentially since it was first launched. And I think, so throughout the pandemic, we've been, as probably many of you will know, we've been reporting latest data insights and latest sort of stats on access to COVID data by researchers over the pandemic. And I just lost the thread of what I was saying.
I mean, do you think this will carry on after
yes.
COVID?
Yes, absolutely. And sorry, so in that reporting, we've had an incredibly quick turnaround in terms of our public and patient representatives commenting on our report that then goes to SAGE. And I think that's only increased over the pandemic. So yes, I think that it's been, but it's a good observation that this won't be including everybody. And I think more and more people are, becoming aware of that and sort of thinking about ways that we can address that going forward. So I think now that that's kind of been fleshed out, we can, we can start to work on how to be more inclusive for different socioeconomic groups and so on.
Any other thoughts on that? Nope. Okay, we have another question. I think this may be our last one. We're at time, but next is a networking event. So if you're able to hold on for another couple of minutes, I think this will probably be our final question. From Hilary, how do we address trustworthiness or build trust with seldom heard groups? Sometimes it does feel that the same people being involved and some people who are hard to reach is a phrase I don't like, but easy to ignore. I think Shamila, if you can just mute yourself, thank you. I think Caroline, if you're able to take that.
Sorry, just got distracted by the second moment. Please say it again, Ben. Thank you.
It was, how do we address trustworthiness or build trust with seldom heard groups? So I'm thinking here, yeah, so perhaps Black, Asian, minority ethnic people, the LGBTQ plus community, maybe elderly people, people with severe disabilities, lots of people who often aren't involved and who should be involved.
And such an interesting and such a tricky question, because how to, it's on so many levels you've got to go into, well, what is the reason for the disengagement or the lack of trust on that? How can we then demonstrate, build the connections? It has to start by conversations, bringing people on board, making the connections from there. Just broadcasting notes out saying trust us clearly is not going to work from that point of view, but actually working with, talking, bringing in people who are representing those groups and actually understanding the root issues in there, ensuring that we're actually working on the areas that matter to them. This is one of the things where we're doing things with the Black Interns program, that if you've got researchers who represent the groups who are not part of this, that they will be thinking about things differently. They'll have different backgrounds, different experiences of life, different aspects that then will mean that the research is done in a way that is more considering the issues that the groups are not represented by. So I think it's really important that we think about it not just from the reaching out to from the engaging of the PPIE point of view, but from the, have we got the data in there? Have we got the research community actually representing that group as well? So I think really quite holistically, sorry, it's quite a long answer, but I think it's a very non-trivial, there's not a sticking plaster answer to that one.
Thanks. No, absolutely. I think representation in amongst researchers is so important. Well, we're out of time. We're actually beyond time. So thank you everybody for all the speakers. Thank you to everybody who asked great questions and the lively discussion in the chat. There's now a short break before the lay members networking event, which hopefully you can all attend. And thank you for your attention and involvement.